Can you hear me?
Yes, sir.
Right. Okay. So we will start. So this lecture is adrenal physiology. We'll discuss physiology of adrenal gland, adrenal cortex, and adrenal medulla. Relatively lengthy lecture, right? So you can see the handouts. It's a relatively lengthy lecture. So as an intended learning outcome, these are the ILOs. You can read leisurely. And relevancy of this content, of course, adrenal gland is related to few disease condition: Cushing syndrome, Conn syndrome, Addison disease, and adrenogenital syndrome, and and some other disease conditions. And this content is related to action of certain drugs, especially antihypertensive drugs. Many clinical relevancy of adrenal physiology. So you will understand them when you are doing clinicals and handling patients. Content. So since this is a lengthy lecture, I divide this into different content area. I will start with the adrenal cortex, then some introduction, then aldosterone, cortisol, adrenal androgen. Then I will discuss the disease condition related to adrenal cortex, and finally we'll discuss the adrenal medulla. Right. So adrenal cortex, we'll start with the adrenal cortex. So probably you remember in the advanced level, in adrenal gland, we have two main area, adrenal cortex and adrenal medulla, right? Majja and Bahike, right? So probably remember. So adrenal cortex is it contains at least three endocrine relevant area, produce at mainly three types of hormone: aldosterone, cortisol, and adrenal androgen. So histologically, it divided into three areas. You will learn, I hope, in the histology: and zona glomerulosa, fasciculata, and reticularis. So mainly aldosterone is mainly from glomerulalis, and so on. You can see these three area is important to certain hormone. This is again complicated diagram, flow chart. You need not to understand, or you need not to remember. Of course, some basic things. So this is area zona glomerulosa. Mainly aldosterone is the end product of this hormonal reaction. So series of, not really hormone, it's some chemicals undergo series of changes and finally produce aldosterone mainly from zona glomerulosa. Next layer, zona fasciculata, again series of chemical reaction finally produce cortisol. Then zona reticularis undergo this reaction and produce testosterone and basically androgen, right? So these are the enzymatic reaction or chemical reaction, and as a final product of this chemical reaction, we get these main three hormone: aldosterone, cortisol, and androgen. But the first product of this chemical structure is cholesterol. So basic chemical structure is cholesterol. I hope in the biochemistry you will learn, and then undergo to some changes, some enzymatic reaction, and converted to next substance, so on, and it will go through a series of alteration of the basic cholesterol structure, and we can call it a steroid, and produce aldosterone, cortisol, and androgen. You know, androgen is basically some sort of testosterone, right? Or male reproductive hormone. So you need not to remember this series of reaction, but remember three area in the adrenal cortex are demarcated with these chemical reactions. Right. So as I mentioned, three hormone mineralocorticoids or aldosterone, important for the sodium and potassium control of or regulation of sodium potassium excretion. Glucocorticoid or cortisol, important for the glucose and protein metabolism. Androgen, we call adrenal androgen, important or less important, actually, less important male reproductive hormone. I would say it's a less important because male, we get the male reproductive hormone from testis. So this adrenal producing androgen are not that important, no little effect on male reproductive function, no, for the male, and of course less, no use in the female. So we will discuss about the mineralocorticoid, cortisol, and to some extent about the adrenal androgen. Right. So when it say this mainly cortisol and uh, adrenaline, these these are the list of substance produced by adrenal cortex. Right. As example, we have cortisol. Cortisol is, of course, we call it a glucocorticoid, but when we consider the action of cortisol, it has very good mineralocorticoid action. That means I will go back to this three hormone mineralocorticoids, important for sodium potassium excretion, glucocorticoid, important for the glucose and protein metabolism. So these are group of hormone. Glucocorticoids are group of hormone, right? So even though under that, so I mentioned it's a group of hormone. So under cortisol, cortisol come under the glucocorticoid. So cortisol is a one type of, cortisol is a one type of glucocorticoid. So this cortisol has a glucocorticoid action. In addition to that, it has a mineralocorticoid action. So that is my main point. Even one hormone like cortisol, we consider it has a glucocorticoid hormone, but it has a mineralocorticoid action also. The same for some other corticosterone. It has glucocorticoid action and very high mineralocorticoid action. Aldosterone, very high mineralocorticoid action, very less glucocorticoid action. So like that. So these hormone, even though they are, we can categorize, so we can broadly categorize them into glucocorticoid and mineralocorticoids, but they have action of other type of action, right? And some of them are drugs. These are synthetic adrenocorticoid hormone, prednisolone. Probably you have used, you know that, right? Methylprednisolone. They also have some glucocorticoid action as well as mineralocorticoid action. Dexamethasone. I'm sure you have used in some of you have used dexamethasone. It has a glucocorticoid action, but no mineralocorticoid action. So on. So this table, I want to highlight you one hormone, one substance secreted from adrenal cortex might have both cortisol and mineralocorticoid action, but probably potent action of one potent action. As example, aldosterone is a potent mineralocorticoid, but very, very weak glucocorticoid. So that is the point I want to highlight, but cortisol has almost equal action. Right. So we'll move to mineralocorticoid. The most potent, most common mineralocorticoid is aldosterone. Here you see this aldosterone. It's a very potent mineralocorticoid. This is the mineralocorticoid action. Right. Very potent. Account for about 90% of mineralocorticoid action is a aldosterone. Right. So basically, when we talk about the mineralocorticoid action, we use aldosterone, but remember other hormone might have some mineralocorticoid action, right? So aldosterone act on renal tubule, right? In the collecting ducts. This is the tubular cells of collecting ducts. You will learn them more details under the renal physiology. And aldosterone, this is the hormone, will act on tubular cells and facilitate reabsorption of sodium. So it reabsorbs the sodium into the cell, and so this is the luminal surface, and put it to the uh, uh, put it into the blood. And same time, it secrete potassium, right? It secrete potassium to the tubular lumen. And actually, basically, tubular lumen mean it's a urinary flow, right? So it will go, it will remove from the body. So sodium reabsorption and potassium excretion is the main action of aldosterone in the renal tubule, right? So, so this is the main regulating step of sodium level and potassium level in the body. Right? So, in other words, as additional effect, when we secrete sodium, or when we reabsorb sodium, probably you know that always it will reabsorb or it secrete water. When we have sodium anywhere, it can retain water and remove water, right? If the sodium reabsorption increase, that will facilitate more water reabsorption. If the sodium reabsorption decrease, that will facilitate more water reabsorption and removal of water, right? So water retention will occur with sodium reabsorption. So that is the action of aldosterone in the renal tubule. So when effect of aldosterone, when there is a excess amount secreted, when we have more aldosterone, you know that we can absorb more sodium. If we absorb more sodium, it will come with sodium, it will come more water, right? If we get more water into the body, water retention will occur in the body, and especially in the blood vessels, more water retention will occur and can increase blood pressure. So when we have more water inside the blood vessel, pressure might increase. More volume, more pressure, right? So opposite will occur if we lose sodium. But what happened about sodium concentration in the blood? When sodium absorb, since water also absorb, probably sodium concentration will not change much. Probably you can understand that very simple concept. If there's a blood vessels, so let's say more sodium absorbed into the blood vessel from the kidney, right? With the sodium, when sodium absorb, water also will come. H2O also will come with sodium, because anywhere when we retain sodium, water, we can retain water. So sodium level, of course, will high in the blood vessel, but water also will high. So it's a concentration wise, sodium concentration will not change much, because since we have water with that, right? So that is something you need to remember. Concentration wise, sodium will not increase, but amount of sodium will increase in the body. Some other concept, when sodium level increase, water retention will occur. With the water retention, some other mechanism will activate to increase the water from the kidney, right? So you will learn it later. There are some other hormone called ANP and so on. So water excretion will increase. So when water excretion, with the water excretion, there's something called aldosterone escape will occur. And we don't get the expected effect of aldosterone, because other hormone will act opposite way. And one such hormone is ANP, atrial natriuretic peptide, will secrete and try to remove water, right? That we call aldosterone escape. And read the concept of aldosterone escape in the Ganon, you will understand, right? So if there's excess aldosterone secretion, of course, sodium will retain or sodium will absorb, but potassium will move out and potassium concentration will reduce, right? And what sodium level will increase and water will retain and sodium concentration will not increase. But we can see reduction of potassium concentration because of the removal of potassium, right? And so mild degree of alkalosis also will occur because again you will learn in the renal physiology. Actually, when I will draw again in the renal tubule, as I mentioned early, we can absorb sodium, and with the aldosterone action, potassium will remove. Actually, when the potassium remove, it will compensate with the H plus. So therefore, we can call when one sodium reabsorb, either one potassium or one H plus will remove, right? So if there's excess aldosterone, sodium level will increase. So actually more sodium will reabsorb, but more potassium, more H plus will remove. So if the more H plus will remove, alkalosis will occur. That means reduction of H plus level in the body, right? So if there's excess aldosterone, potassium level will reduce. Same time, H plus level also can reduce when sodium absorb into the body, because when one sodium absorb, either one potassium or one H plus should remove. Under the renal physiology, you will learn this more. Remember that at the moment, when one sodium reabsorb, one potassium or one H plus will remove from the body or remove to the renal tubule, right? So therefore, if there's excess aldosterone, more sodium will reabsorb. Same time, more H plus might remove and alkalosis will develop, right? So this is possible consequences of uh, high aldosterone level in the body, right? Right. So then, not only in the renal tubule, aldosterone will do the same job in said gland, probably under the gastrointestinal physiology. In the first or second lecture, we learned about the salivary secretion. In the salivary secretion, so I mentioned about the uh, uh, exchange of sodium in the tubule. So where sodium secretion will sodium reabsorption will occur more with the action of aldosterone in the said gland, actually duct of the said gland. Sorry, duct of the salivary gland, and same thing will occur in the said gland and some other places in the intestinal epithelial also. Sodium reabsorption will stimulate with the aldosterone, right? So regulation of aldosterone secretion, so that is interesting. There are few regulatory mechanisms, right? When aldosterone secretion will increase from adrenal cortex when with the increase of potassium concentration, right? So you can understand, when the potassium concentration increase, we need to remove the potassium. Removal of potassium will be done by aldosterone when it exchanges the sodium. So when we have high potassium, we need to remove that. To remove that, we need aldosterone secretion will increase from adrenal cortex. That is one thing. Then additional things, we have something called renin-angiotensin system. So that is interesting, important system, renin-angiotensin system. So renin-angiotensin system will also activate aldosterone secretion. ACTH, you learn about the ACTH secreted from pituitary. Of course, ACTH is important for the cortisol secretion, regulation of cortisol, but not for the aldosterone. Little effect on real rates of secretion of aldosterone. And increase sodium ion concentration in the excessive fluid to also slightly decrease the aldosterone secretion, but mainly potassium and renin-angiotensin system is important to control the aldosterone secretion. Right. So this is renin-angiotensin system. So actually renin is a hormone secreted by the kidney, right? So there's a place in the kidney called juxtaglomerular apparatus. I think you learn in the advanced level. Secrete renin. So renin secreted from this place will act on angiotensin organ to convert angiotensin 1, and then angiotensin 1 is converted to angiotensin 2, right? So we get the angiotensin 2. Angiotensin 2 will act on adrenal cortex and stimulate the secretion of aldosterone, right? Aldosterone is coming from adrenal cortex with the action of angiotensin 2. Angiotensin 2 is actually a production of angiotensin 2 is initiated by renin secreted from the kidney, right? So this renin secretion is stimulated by sympathetic discharge to the kidney. You know, sympathetic, parasympathetic nerve cells, nerves coming from coming to many organs, right? So with the renal sympathetic discharge, renin secretion will increase. In addition to that, decrease renal arterial pressure. That means blood pressure coming to the kidney. Let's say this is blood vessels. If the blood pressure in the blood vessel reduce, renin secretion increase. So there are two main mechanisms to activate renin. One is sympathetic activation to the kidney. One is blood pressure or renal arterial pressure reduction will activate renin, right? So renin secretion will increase, and then finally it will stimulate the aldosterone secretion. In addition to that, decreased sodium level might do some manipulation to increase renin, but definitely increase potassium level will increase the renin secretion, right? So renin secretion is aldosterone secretion is regulated through the renin-angiotensin system. Right. So we'll erase this. So read about the renin-angiotensin system. It's very important. You will learn more in the renal physiology, but you should have you should understand how it operates in the in this endocrine in endocrine physiology. Right. So I think you have seen this earlier, how brain control different hormones, like I mentioned about the pituitary, anterior pituitary action of through the hypothalamus and so on. So here, renin secreted from juxtaglomerular cells through the sympathetic activation is shown here, right? So that is one way brain control the renin secretion and subsequent to aldosterone secretion, right? Okay. Right. So about sodium level, because sodium is a very important electrolyte, and we should regulate sodium level very carefully in the body. If there's excess sodium, we get the problem. If there's a low sodium, we get the problem. So regulation of sodium, there are many factors control the sodium secretion. One is aldosterone. Right? I already mentioned. So aldosterone will act on renal tubules, reabsorb aldosterone, and of course, together with that, excretion of potassium. So in the in this mechanism, renin-angiotensin important for the aldosterone regulation. In addition to aldosterone, which regulates sodium excretion in the renal tubule, sorry, sodium reabsorption in the renal tubule, We have ANP, some other hormone, right? ANP is some other hormone, atrial natriuretic peptide. Atrial natriuretic peptide. Actually, it's secreted from heart, right? So heart muscles will synthesize it. It secrete and it will do the opposite action of aldosterone, right? Aldosterone will reabsorb sodium. ANP will remove the sodium from the renal tubule, right? So it's the opposite action of aldosterone. So they are uh, in opposite action, right? Aldosterone will reabsorb sodium. ANP will remove sodium. In other words, aldosterone by reabsorption sodium will increase the water content in the body. ANP by removing sodium reduce the water content in the blood. So it's the opposite effect of uh, aldosterone and ANP. So in addition to that, sodium concentration is regulated by GFR. You will learn that under the renal physiology, osmotic diuresis, tubular reabsorption independent of aldosterone, that is angiotensin 2 can directly act on renal tubule other than it acting through the aldosterone, right? So here, mm, here probably you remember, this is angiotensin 2. It can act on adrenal cortex and increase aldosterone. But this angiotensin 2 can directly act on renal tubules and reabsorb the sodium in the proximal tubule. Remember that. Angiotensin 2 can reabsorb sodium in the proximal tubule. Other than that, angiotensin will act through the aldosterone to reabsorb sodium in the collecting duct of the renal tubule. Right. So these are the mechanisms to control sodium concentration in the body. You can you will learn them under the renal physiology like GFR and so on. I will not describe them, but we have many mechanisms, at least few mechanisms to control sodium concentration in the body, because sodium is a very important electrolyte, you know, in the extracellular compartment. That is the main electrolytes. Right. Okay. As a summary about aldosterone so far, what are the main action? Aldosterone reabsorbs sodium in the renal tubule. And of course, reabsorbing sodium, it reabsorbs water. It facilitates water reabsorption. And same time, it removes potassium and H+. And regulated by renin-angiotensin system and not much by the ACTH. It associates with hypertension because if retain water, it can retain increased blood volume and hypertension. It associates with hypertension, sodium concentration, potassium concentration, and pH alkalosis. Right? If it is excess aldosterone, remove H+ and lead to alkalosis or reduce the pH or reduce the H+ level in the body. So that is the summary of aldosterone. Please read again and try to understand this operation. It's important. Right. Okay, we'll move to next step. So far, I try to describe about aldosterone. That is the main mineralocorticoids secreted from adrenal cortex. Important regulate sodium level and of course potassium level and water content in the blood. Okay, right. Now I will move to the cortisol, glucocorticoids, right? Glucocorticoids, the main hormone is cortisol. Remember, of course, we call cortisol is the main glucocorticoid. Cortisol has a very good mineralocorticoid action that I already explained. But as a glucocorticoid, cortisol is the potent or most important glucocorticoid is cortisol. Right. So let's discuss about the cortisol. Right. Glucocorticoid, mainly cortisol, is very potent one, account for 95% of glucocorticoid activity. And there are many synthetic cortisol. we use them as a drug, prednisolone, cortisone, methylprednisolone, dexamethasone. I'm sure some of you have used dexamethasone and prednisolone due to respiratory tract problem or bronchial asthma, so on, asthma and so on. Right. So glucocorticoid stimulated, stimulated by cortisol increase action, cortisol increase the conversion of amino acid into glucose in the liver, right? So basically cortisol is important for the glucose and protein metabolism. I already explained, right? So glucocorticoid, we can say cortisol, is important for the glucose and protein metabolism. So it basically increase glucose level and try to increase glucose level and try to break the proteins, right? So as a summary, right? Summary of action of glucocorticoid. You can remember it break protein, protein, right? So it break the protein, break protein and use this amino acid and send it to the liver and produce glucose, gluconeogenesis, right? So basically it increase glucose level by this way and break the protein, right? Break the protein, probably use this amino acid and increase the glucose level. So cortisol increase conversion of amino acid into glucose in the liver cells, and cortisol mobilize amino acid. Mobilize mean it break the protein and mobilize amino acid and use them in the liver, right? By this way, it increase the plasma glucose level and same time decrease the utilization of glucose by the cells because it want to maintain the glucose level high. Therefore, it decreases glucose utilization by the cells, not by brain cells, other cells, right? So as action of cortisol, you can remember these three things: break protein, use amino acid, and produce glucose, and therefore it increase the glucose level. Right. So we'll erase this part. Right. 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 Function of glucocorticoid, it's reduction of cellular protein, decrease protein synthesis, and increase catabolism of protein. I already explained. Increase liver and plasma protein, and increase blood amino acid because it transport amino acid from with the breakdown of protein. It transport amino acid to the liver and mobilize. In addition to that, it mobilize fatty acid, and basically it break down the fat also and use this fatty acid for the synthesis of glucose. In addition to this main action of carbohydrate, that means glucose production, protein breakdown and fatty acid, it has some other minor action. Glucocorticoid has minor action that we call permissive action, right? Podi vada tika, right? Permissive action. This word is important. Permissive action. It's not a major work. Permissive action. And what are these permissive action? It's important for the action of catecholamine. Catecholamine is adrenaline or adrenaline. And action of glucagon, right? So action of this hormone, glucagon, catecholamine, cortisol will play a minor role. Podi help එකක් දෙනවා. Cortisol podi help එකක් දෙනවා for the action of catecholamine and glucocorticoid, and therefore it's called permissive action. So it's a minor effect, right? Not the major action of cortisol. right? So in addition to that, cortisol is important to resist the stress. Cortisol is a stress hormone, right? When we are stressed, cortisol secretion increase. When you are close to the exam, probably your cortisol level is very high. When there's any other stress, some other stress situation in your life, cortisol level increase by the action of ACTH. ACTH secreted from pituitary under the control of hypothalamus. ACTH level will increase, and cortisol level, glucocorticoid level will increase, and that might help. That permissive action might help to, of course, for the activation of sympathetic nerve system, right? And of course, if we are in the stress, we need probably more energy, so rapidly mobilize amino acid fat for the energy production, right? So that is a function of glucocorticoid. And in addition to that, it has some minor effect we call anti-inflammatory action. Of course, it's a minor effect, but we use glucocorticoid drugs to get this anti-inflammatory action. Anti-inflammatory mean it inhibits the inflammatory process, right? So probably you have some idea of what is inflammation. When we get the injury, with the bacteria inversion into our body, a series of reaction will occur, especially with the tissue damage. There's a process of inflammation, right? Redness, increased blood flow, if the bacterial activation, immunological action. So this inflammatory reaction is inhibited by cortisol. So anti-inflammatory action, especially this anti-inflammatory action, we use cortisol drugs. We have drugs, prednisolone, dexamethasone, and some cream, skin cream. They have anti-inflammatory action. They are cortisol. This anti-inflammatory action will help to control the inflammation in our body, because some inflammation is bad, not good, and make problem to us. So this cortisol is commonly used as a drugs with this anti-inflammatory action. Right. So regulation of cortisol is it's simple, not like aldosterone. ACTH coming from pituitary. You know, ACTH is under the control of corticotropin releasing hormone, and ACTH act on adrenal cortex and release the cortisol, right? So it's a directly pituitary control hormone through the ACTH, right? Not like aldosterone. Aldosterone is regulated by some other mechanism, renin-angiotensin system, and so on. Cortisol level will fluctuate during the day, and here you can see the timing. This is basically midnight to noon, then again noon to midnight. So you can see high level we can expect in the around 8, 9, 10. That means in the morning we can get the high cortisol level and then reduce. Right. So this type of variation within the day we call diurnal variation. Right. So within the day, cortisol level fluctuate highly. Right. So therefore, if we want to get the blood sample and assess the cortisol level, it's difficult, because we can get a very high level in the morning time. If it is evening, cortisol level is low. So getting cortisol level and detecting cortisol level in the blood is not helpful directly to detect the cortisol level, because of this diurnal variation of the cortisol level. Right. So I mentioned about this ACTH, right? It's a pituitary hormone, important to regulate the cortisol from the adrenal cortex. But this ACTH will will have some other structurally similar substance, that is MSH, right? So MSH is a called melanocyte stimulating substance or melanocyte stimulating hormone. So the ACTH and MSH share the common precursor. Let's say this is the substance X. Substance X will convert it and produce ACTH, and same thing will convert and produce MSH, melanocyte stimulating hormone. That will determine our skin color, right? If there is a more MSH, you will be more dark color, right? So what happened? This is the common substance. If there is a excess production of ACTH in our body, to produce more ACTH, we need to produce more POMC, propriomelanocyte protein. And if we produce more this substance, some of will, as a byproduct, be converted to MSH, right? Problem is excess production of cortisol, ACTH, but since we produce more of this substance, some MSH also will produce excess, right? That is important. When we have more ACTH, in our body, we might have more MSH, and our melanin production will increase, and we don't get unwantedly dark colors in some places in our body, right? So you will learn it later under the high cortisol level. Right. Right. As a summary about cortisol, it's important for the glucose and protein metabolism. Since it increases glucose level, we can call it a diabetogenic effect, because in the patients with diabetes, problem is include glucose. So it's a diabetogenic hormone, and decrease protein synthesis and increase catabolism of protein and use amino acid to do something else. And it's a stress hormone. It has a inhibitory action of immunity. Therefore, we call anti-inflammatory hormone. And anti-inflammatory drugs will produced by the derivatives of cortisol and controlled by ACTH, not like aldosterone. It controlled by renin-angiotensin system and other mechanism, but cortisol is controlled by ACTH secreted from pituitary. Right. So that is the summary of cortisol. Then we'll move to the adrenal androgen. Right. Other adrenal cortical hormone. We discuss aldosterone, mineralocorticoid, glucocorticoid, and adrenal androgen. That is a hormone which is not that important. නිකන් ඔහේ තියෙන hormone එකක් වගේ. Right. පොඩ්ඩක් level එක වැඩි වුණොත් තමයි we get the problem. Right. Right. So adrenal androgen, male sex hormone from adrenal cortex, but moderately active, less than 20%, because we get testosterone, that is the main androgen, from testis. So it's not that important. This level also regulated by ACTH level, adrenal androgen level, regulated by ACTH, not like testicular hormone, which is regulated by LH and gonadotropin hormone. Very little effect in normal amount, so it's not that important, but excess amount. If we secrete excess androgen, adrenal androgen, and then we get the problem. Right? What happened in the male? If there is an increase adrenal androgen, adult male, no problem again, because anyway we have excess androgen from the testis. But in the male children, right, not adult. How about, let's say, age 5, male child. Hmm? What do you think about the uh, testicular androgen production of this child? මොකද කියන්නේ? Testis එකෙන් androgen හැදෙනවද? The child age of 5. Hmm? Yes, question. Question to you. Yeah, we are advanced knowledge. Yes. මොකද කියන්නේ? Right. Yeah, I think it's very simple questions. If you know you don't answer, I will give you a 2-3 minutes. So you can. Yes. What do you think? Yes. 5-year-old child, right? What you can say about testosterone or male sex hormone production of this child, testicular hormone production? Hmm?
It will not there.
Yes, it
Not
will
secure.
not there because it's in the after puberty. Uh, Only after puberty, male testes start to produce testosterone, right? But if there's excess androgen, if there's excess androgen in this child, then at that age, he start to develop the secondary sexual characteristic. Because now he get the androgen or testosterone. Basically, androgen is, we can call it a testosterone from other source, that is adrenal gland. And so that is a problem. If there's a excess testosterone or excess androgen coming from adrenal, that is a problem. And he get the male-like features. We call masculinization. Excess male-like features. So one example, child get the increased androgen from adrenal cortex. He get the secondary sexual characteristic early than expected. So I hope you learn about the secondary sexual characteristic in the advanced level, and you will learn more in the reproductive system that we call uh, uh, precocious pseudo puberty. Because externally, secondary sexual characteristic will develop early. Precocious mean early. Early development of secondary sexual characteristic or early development of puberty in the male. In the female, right? In the female, of course, adrenal androgen, or anyway, androgen, testosterone is not an important hormone, right? In the female, especially again in the before the development of secondary sexual characteristic or in the very early days, if you get the increased androgen, they will get the external male genitalia, because androgen or testosterone is important to develop the external male genitalia, right? Penis and so on, right? So that then in the excess secretion of this hormone will make problem in the female, in the not adult male, adult, I mean, male children's, it can be a problem. The female, it can be a problem. Right. So, adrenal androgen, as a summary, it's not important for the male or female, but excess production can be a problem. Right. So, as a summary, you remember, but I will discuss later disease condition related to this hormone. Right. So, now I discuss about the aldosterone, cortisol, very briefly, adrenal androgen. Now I move to a disease condition related to this hormone, adrenocortical hormone. Right. So, first, Addison's disease, that is hypersecretion of adrenocortical hormone, right? Production of mineralocorticoid and glucocorticoids are low. So, there is a insufficiency of adrenal cortex, and we call Addison's disease. Cortisol, aldosterone production is low. You can understand, if there is a low aldosterone, sodium reabsorption will be impaired and sodium level will reduce. We call hyponatremia. Low sodium, right? Because of the, I already explained, sodium reabsorption will be impaired, and natremia means sodium, hyponatremia means sodium level decrease in the body. Right? If there is a low aldosterone, what will happen to the potassium level? Now we have low aldosterone. Potassium level වලට මොකද වෙන්න ඕනේ?
It will decrease.
Potassium level increase.
Potassium level increase, because you remember, when we absorb sodium, we excrete potassium OH plus. Ne? Potassium OH plus, right? So when we don't get aldosterone, adequate aldosterone, hyperkalemia, potassium will accumulate in the body. Right? And same time, what can happen to the H plus? If there's no aldosterone, H plus.
It also increases.
It also increases, so mild acidosis will occur. Right? So low sodium, high potassium, high H plus will be features of Addison disease. If there's a low sodium in the body, what will happen to the water level of the body? Right? If there's low sodium, water. So I already mentioned, if there's a sodium reabsorption, water also will reabsorb. So if there's no sodium reabsorption, water
level reduce.
Water level reduce and water reabsorption will be impaired. If there's a low water level in the body, we will get hypotension. Blood pressure will reduce. BP will reduce. Right? Blood pressure will reduce. Right? So blood pressure reduction. These are features due to aldosterone effects in the Addison disease. You know that in the aldosterone, the problem is not only the Addison disease, problem is not only mineralocorticoid, not only aldosterone, but cortisol also. So as a cortisol deficiency, they might get the hypoglycemia. Because as I mentioned, cortisol important to produce glucose. Right? It break down amino acid and so on and increase glucose synthesis in the liver. So easily they can go to the hypoglycemia, especially fasting will make a severe hypoglycemia. So these are possible features of Addison disease. Then cortisol important for the stress, important stress hormone, probably inability to cope with stress is possible. And if it is severe Addison's disease or severe deficiency, even death is possible with hypotension and hypoglycemia. And then we call Addisonian crisis will occur suddenly. Especially if you start to fasting, your blood glucose level quickly reduce, and pressure also can reduce, and even death will occur. We call Addisonian crisis in Addison's disease. Right. So that is due to deficiency or impairment of adrenal cortex. Right. Then right. Uh, right. So in the Addison disease, as I mentioned earlier, when there is a low cortisol level, what can happen to the ACTH level? Cortisol අඩු නම් ACTH වලට මොකද වෙන්නේ? හිතලා කියන්නකෝ.
It will be
The-
increase.
Yes, ACTH level increase, right? So ACTH level increase. So as I mentioned earlier, when the ACTH level increase, the precursor to produce ACTH also will increase, and some of this will convert to MSH. MSH is a melanocyte stimulating hormone. It stimulates your melanocyte in the skin and produce more melanin. So with the Addison's disease, MSH will increase and more melanocyte will be activated, and you will get the melanin production in some places. And therefore, spotted pigmentation in the skin, gum, and palm, like palm, you might get the dark pigmentation in the with the Addison's disease. Right. Then primary aldosteronism, that means secretion of large amount of aldosterone, opposite of Addison's disease. Conn syndrome, we call Conn syndrome, where production of aldosterone increase. If the production of aldosterone increase, what can be the result? Sodium වලට මොකද වෙන්න පුළුවන්? Sodium වලට?
Sodium amount is increased, potassium level is decreased.
Yes, good. Potassium level decrease and they get the hypokalemia. Sodium reabsorption increase. With the sodium reabsorption, water also reabsorb. So sodium concentration will not increase much because it will dilute with the absorbed water. But total blood volume will increase and sodium level can increase slightly. But definitely total blood volume increase. If total blood volume increase, what can happen? What are the next step, next consequence? Blood volume එක අඩු වුණොත් මොකද වෙන්නේ? What will happen to the pressure if the volume increase?
Pressure increase, blood pressure increase, hypertension.
Yes, so they will get the hypertension. So in the Conn syndrome, hypokalemia, blood volume increase, excessive fluid volume increase, and hypertension will occur. Very slight increase of sodium concentration is possible, but hypertension is a mark feature because of the sodium and water retention. And of course, renin secretion depressed in the Conn syndrome. Those are the features of Conn syndrome. Sometimes there is a condition called secondary hyperaldosteronism. So that is not due to adrenal cortical in activation and production of aldosterone, but due to some other reasons. As example, if our renin secretion increase, right, due to some problem, our renin secretion increase. මොකද වෙන්නේ? If our renin secretion increase, renin-angiotensin mechanism activate and we get more angiotensin 2 and act on adrenal cortex and aldosterone secretion increase. That is we call secondary hyperaldosteronism. That is due to secondary cause. Not purely aldosterone secretion or not purely aldosterone production increase, but aldosterone production increase due to some other reasons. We can see that in the cirrhosis, right? In the heart failure, in the nephrosis, in the cirrhosis, what happened actually? Aldosterone breakdown will reduce. In the heart failure, hypotension will stimulate renin secretion, right? Renal artery constriction, renal ischemia and renal blood flow will reduce and renin secretion increase. So all these will lead to secondary hyperaldosteronism. Secondary කියන්නේ වෙන එකක් නිසා වෙන එකක්. Directlyම aldosterone stimulate වෙන එක නෙමෙයි, aldosterone production එක directly වැඩි වෙන එක නෙමෙයි. Secondary, right? Then come to the Cushing syndrome. That is the increased cortisol secretion, right? So I discuss increased aldosterone secretion. Now increase cortisol secretion. That we call Cushing syndrome. So due to some problem in the adrenal cortex, we get the excess cortisol production, or maybe some cortisol like steroid we can give outside as a drug. Sometimes we use cortisol like drug, prednisolone, dexamethasone for a longer period. Then it's like excess cortisol in the blood. Excess cortisol production or excess cortisol like drugs coming from outside. Cortisol like substance coming from outside. It's cortisol secretion can be due to pituitary problem and increase ACTH or pituitary independent adrenal cortical tumor that produce cortisol. These possible. So these are the features of cortisol. As I mentioned earlier, now we have excess cortisol. If there's excess cortisol, what happened? It will break down the protein. What are the main source of protein in our body? Is the muscle. It breaks down the muscle. So we get the poor muscle action, muscle size, and then these amino acids will be mobilized to the liver and produce glucose, and probably they will develop diabetes, right? And so the fat cortisol will affect the fat metabolism also. It called fat redistribution. In the some places, fat will be deposited like in behind the neck and in the tummy, in the face, fat will be deposited, and low fat in the arm, lower limb, upper limb, low fat. So upper limb, lower limb will be thin, and the tummy and face and backside of the neck will be deposited fat deposition, and we call buffalo hump. අර buffalo ගේ තියෙන hump එක වගේ මෙතන fat deposit වෙනවා. And the abdomen, we get the increased abdomen. Because of the increased abdomen, striae will make and so on. And as I mentioned earlier, cortisol has a mineralocorticoid action. Remember, I mentioned. So, action of mineralocorticoid of cortisol will retain sodium and water, and hypertension will develop, right? So, hypertension is possible, and all these features will possible. You can read them, try to understand, and read about the features of Cushing syndrome. I will not go into describe them, and bone destruction of bone will occur and so on. So list of problem. So these are the poor wound healing again due to fat breakdown, and so on. Right. So insulin resistant diabetes, as I already mentioned, because of cortisol and so on. Right. So again, these all are Cushing syndrome features. You can read and you can understand features. Right. So now conditions or abnormalities related to adrenal genital syndrome. Right. So it's a ad, 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 adrenal androgen excess secretion, right? So as I mentioned early, it's if the tumors in the adrenal cortex, if the and reduce more androgen, we get the increased androgen, male-like features. In the female, if it is happen, female will develop male-like features. We call adrenogenital syndrome. That will be a problem for the female, not for the male. They will get the female get the male-like features, growth of beard, voice changes, baldness, male-like hair pattern, and so considerable male-like features will develop in the female in the adrenogenital syndrome. And it's due to some impairment of synthesis of enzyme in the process of steroid hormone synthesis. The same diagram I use. Here, there is a deficiency of this hormone. Since it deficiency, cortisol and mineralocorticoid production will impaired, and most of the substance will shift to this direction. If it is shift to this direction, it will produce more androgen or testosterone, and then get the excess production of this hormone and get the features, and it's a problem for the female, not for the male. Then there's a condition called adrenal hyperplasia. You can read that condition. It's due to excess secretion of ACTH, and again it will affect the female genitalia develop regardless of genital sex. Right. Now up to here, I discuss about the adrenal cortex. Hormone here and abnormal conditions related to adrenal cortex. Now I will move to the adrenal medulla. Right. I hope you don't have a lecture now. Lecture at Tino Dagolanta. 11:30. Tino the huh?
No,
No,
sir.
sir.
Okay, so I will continue another 5 minutes. Right. So adrenal medulla. So now I will move to the adrenal medulla. Up to now I discuss adrenal cortex. Right. So adrenal medulla will produce catecholamines, circulating catecholamine. That means adrenaline and noradrenaline. Or in the Gannon might say epinephrine and norepinephrine. Right. Mainly circulating adrenaline coming from adrenal medulla. Noradrenaline secreted from nerve endings. Sympathetic nerve endings mainly secrete noradrenaline, but of course some more noradrenaline will come from adrenal medulla. But mainly noradrenaline come from nerve endings. Nerve endings will secrete, some of them will enter the blood. But adrenaline coming from adrenal medullary as a hormone. Some other hormone called dopamine also secreted from adrenal gland and will play a minor role, and dopamine also not that important. Function. Of course, adrenal hormone important for the sympathetic activation. When our sympathetic system activate, sympathetic nerve supply will directly act on adrenal medulla and secrete adrenaline to the blood. So blood adrenaline level will increase in with the sympathetic activation, flight and fight reaction, and we will get the many activation of many systems, right? So effect lasts very short, so therefore continuous secretion is important. In addition to that, important for the gluconeolysis in the liver, the skeletal muscles, mobilize fatty acid, also influenced by adrenaline. Noradrenaline do some sort of vasoconstriction, produce vasoconstriction most, if not all the organs or many places. Vasoconstriction. But adrenaline will dilate the blood vessels, and mainly important to dilate the blood vessels and provide good blood flow. But noradrenaline vasoconstriction do the vasoconstriction in most of the organs. So there's a difference between adrenaline and noradrenaline action, right? So if I repeat again, noradrenaline is a vasoconstrict hormone most of the places, most of the organ. But epinephrine probably dilate the blood vessels, skeletal muscles and liver. So it's a dilating hormone, at least skeletal muscles and blood. You can understand when sympathetic activated, we need to provide more blood to the skeletal muscle, because skeletal muscles are active because we are running or jumping, running, fight or flight reaction. But other blood vessels, we need to provide good blood flow and increase blood pressure and so on. So we increase the vasoconstriction. Right. And there are receptors, sympathetic receptors, alpha receptors and beta receptors in different places. And noradrenaline mainly secreted from nerve endings will act on alpha receptor, to some extent beta receptor. So epinephrine secreted from adrenal gland will act on both type of receptors. And you should have some idea about the location of this receptor, beta alpha 1, alpha 2 in the blood vessels, beta 2 especially in the respiratory tract, in the heart and so on. This hormone, right? So this adrenaline and noradrenaline metabolize, and this metabolize will secreted through the urine, right? There are two metabolites product, methylepinephrine and vinyl mandelic acid, right? If you want to see whether we produce high level of adrenaline, we measure these two level in the urine. There's a condition called pheochromocytoma, I will explain later, where adrenal gland will activate and produce more adrenaline. In pheochromocytoma, this level will, we can detect high level of these substance in the urine, and that will help to diagnose the pheochromocytoma. Dopamine effect, not that important, not an important hormone, but probably dilate the renal and mesenteric vessels. That, remember, because of this action, dopamine and dopamine-like drugs will be used for some instances in the hypovolemic shocks and so on. Otherwise, dopamine is not that important hormone. Regulation, that is important. Sympathetic system directly regulate the adrenal medulla. Sometimes you forget that. Let's say this is adrenal medulla. Directly from the brain, sympathetic nerve supply now act on adrenal medulla and secrete adrenaline, right? Directly from brain through the sympathetic nerve control the adrenal medulla, right? Sometimes you forget it, the regulation of adrenal medulla, because it's not under the regulation of pituitary. It's under the direct regulation of sympathetic system from the brain, right? So catecholamine secretion increase resting secretion is very low, but further low in the sleeping, but stimulated by physical activation, emotions, cold weather, hypotension, and so on. So this situation, catecholamine secretion will increase, especially sympathetic activation, it increase. ACTH does not regulate adrenal medullary hormone. Remember, ACTH control adrenal cortical hormone. But indirectly, ACTH has some control on the adrenal medullary hormone. You can read them in the Ganon. You can understand that ACTH not that important for the adrenal medullary secretion. It's mainly sympathetic directly control the adrenal medullary secretion. So condition of pheochromocytoma. It's a basically excess production of adrenaline from the adrenal medulla, right? So if there's a excess secretion, you can understand excess activation of sympathetic system, right? Excess activation of sympathetic system, generalized vasoconstriction will occur and we get the hypertension. It will act, adrenaline will act on heart. We get the tachycardia, setting, hyperglycemia because of the activation of gluconeogenesis and so on. So it's a very serious condition. We can get the very high blood pressure. Sometimes it's a episodic occurrence of increased blood pressure with these features, right? Of course, people will get hypertension. Your mothers, fathers, grandmothers, grandfathers might get the hypertension. But in pheochromocytoma, blood pressure will be very high. Very high. Right. So to diagnose, as I mentioned earlier, we check the urinary level of these metabolites of adrenaline, right? And you can read that we collect the 24-hour urine sample and measure the total amount excreted within a 24-hour period. Right. So this, I think this diagram I have shown you many instances. And here you can see how we control adrenal medulla. Directly, sympathetic system act on adrenal medulla, secrete adrenaline and noradrenaline. And this is the secretion of ACTH and FSH, LH, and so on. From the pituitary, secrete the hormone and so on, right? And this is secretion of this one, renin-angiotensin system, I already explained, right? So that's all for this lecture. Any questions? Anything you want to ask? It's a lengthy lecture than normal. මොනවද අහන්න තියෙනවද?